Okay. That's all right. Thank you. Thank you. All right. This is pretty. Okay. Should we turn off the light?
If you like.
Or bring it down a little bit? Okay. Well, most of the faces here are very familiar to me. I guess I don't know you back there, but I'm Andrea Alvarez. I did internal medicine here, geriatrics here. Now I'm doing endocrine. And I thank you for the invitation to share what I've learned so far about diabetes in the elderly with y'all. And well, they asked me to outline what the talk would be about, and so I'm going to first of all briefly describe and review with y'all the pathophysiology of type 2 diabetes. Then we'll move on to define appropriate goals of treatment for diabetes in the elderly. Then we'll review the mechanism of action of different oral hypoglycemic agents, and we'll finally end up by reviewing a case and going over the ADA algorithm. But you know, really that's kind of the formal outline, but really what I want to bring is just some clinical practical tips to the fellows on how to, you know, manage type 2 diabetes in the clinic. So this is a real case from clinic that I had at the beginning of the year. I'm gonna do kind of the HPI, try to keep it in mind, and then we'll discuss what we would do with this patient at the end.
But Andrea, this is merely an elderly patient.
Well, 65 is like a
Not much older than
Medicare.
I am.
Medicare defines elderly as 65 and older. So, so this is a 65-year-old Hispanic male. Past medical history significant for hypertension, obesity, and osteoarthritis. He comes in concerned about 2 months history of polyuria, polydipsia, blurred vision, fatigue, and worsening impotence. His past medical history is significant for hypertension and the lumbar disc disease. Medications he takes ibuprofen. Family history, both parents developed type 2 diabetes in his early 60s. Social, he's divorced. So now he lives by himself. He has 2 kids, but they live out of town, and he's a retired police officer. He just retired. He's just at home all day, sitting down, watching TV, very sedentary. At the physical exam, blood pressure is 140/100, heart rate is 100. He is fairly obese. And there's so far no evidence of an organ damage, but a little bit of neuropathy. At the initial lab test, that he has a fasting blood sugar has been borderline high during the last 2 years, somewhere between 100 and 130. So he's had diabetes for quite a while. Random sugar is 230. That's the after check right before they come into the clinic. Hemoglobin A1C is 9.5. Creatinine is 1. GFR is 76. TFTs are normal, and the fasting lipid profile is remarkable for TG of 230 and normal LDL and HDL. Can you hear me back there? Okay. If you don't, just let me know. So questions. Which one would be the first line therapeutic agent for this patient? Right. Which would be the target hemoglobin A1C in this case? I hear 7, 6. Okay, we'll go with that. And which are the limitations that will keep this patient from achieving his target hemoglobin A1C? Sedentary.
Or social support.
Diet, social support, obese. Okay. All right. So why is it important for geriatricians to talk about diabetes? Well, diabetes increases with age. If you take a group of people between 25 and 45 years old, you'll find the prevalence of diabetes is 1.8%. 45 to 54 it increases to 3.6, 55 to 64 7.8, and from 65 and above it ranges anywhere from 10 to 20%. So it's very prevalent, and there is a clear association of increasing age and worsening glucose tolerance.
Is that across all ethnic
Ethnicities,
groups?
yes. This other graph is pretty old. It's from 1996, but it just show you how in patients above 65 years old, the incidence of impaired glucose tolerance is as high as 50%. Undiagnosed type 2 diabetes is usually somewhere around 25%, and diagnosed type 2 diabetes is only 15 to 20%. So really, half of the patients we see in the clinic, by the time we're seeing them in the clinic, they're older than 65, they have some sort of impaired glucose tolerance. It's just it take us a lot to label them and diagnose them as such. Why aging is a risk factor to develop insulin resistance? Well, as we age, we develop sarcopenia, which is our muscle mass decreases, and when our muscle mass decreases, and because of all the other social factors of the elderly, the physical activity decreases, the energy expenditure decreases, so it's a lot more when we eat than what we really spend in calories, and that all leads to obesity and abdominal fat. Those two factors inhibit insulin signaling, so that increases insulin resistance. The sarcopenia also is very important because when we eat an oral glucose load, most of the glucose as soon after we eat it is uptake by the muscle, and the less muscle we have, the less glucose disposal we have, and so more of the glucose is being just hanging around for longer in the blood, and that leads to insulin persistent hyperglycemia. So another factor is as we age, we have less number of beta cells in the pancreas, and they become to be defective with age. So we not only have less muscle mass to uptake the glucose, but we also have less beta cells in the pancreas to secrete insulin, so that there is a decompensation there. When we develop abdominal adiposity, that creates insulin resistance, and a phenomena that is more significant in Mexican Americans is the Down phenomena. That is, that we have increased glucagon production by the liver at night. So instead of going to bed with 100 and waking up with a glucose of 100, we go to bed with 100 and we wake up with 300, because overnight when we were not eating, our liver has been producing a lot of glucose unnecessarily.
And this happens in people whether they're diabetics or not, or
diabetics.
They increase
No, this
gluconeogenesis?
is mostly seen in Mexican Americans with genes of type 2 diabetes. This increased glucose output by the liver at night. Now, in the cellular level, the main hypothesis now, and the main thing that all the investigators are looking at, is the mitochondria. We believe that as we get older, we have less mitochondria and they're less functioning. So for the same amount, for a same given amount of glucose and fatty acids, we produce less ATP and more free radicals. And that, along with the increased cytokines that are seen in elderly people, that all creates kind of a low grade of inflammation. Aging is kind of a low grade inflammatory state that leads to insulin resistance. And why is it important to understand all these mechanisms? Well, diabetes is the common background for most of the geriatric syndromes that we have to deal with our patients. Uncontrolled diabetes, for long-standing uncontrolled diabetes, leads to atherosclerosis, and atherosclerosis leads to functional disabilities like blindness, amputations, and amputations leads to recurrent falls. Also, atherosclerosis is kind of the pre-stage of microvascular disease, and microvascular disease can lead to cognitive impairment, depression, dementia. Poorly controlled diabetes also leads to nerve damage, and that can lead to urinary incontinence, impotence, and persistent pain. So if you see, most of the problems we have to deal with in our geriatric population have as a common pathway diabetes. And not only the morbidity is significant in the elderly, but the mortality. We know that elderly diabetics have a higher rate of premature death compared with their non-diabetic counterparts of the same age, same ethnicity. If you're diabetic and you're male, you have twice double the chance to develop a deathly or a lethal cardiovascular event. If you are a diabetic female, you have 4 more times chance to develop a lethal cardiovascular event. And both females and males have double the chance to develop stroke compared with a non-diabetic counterpart of the same age. So knowing all this, knowing that there's such an increased morbidity for the elderly and increased mortality, one would think that we should all go at diabetes very aggressively. And many studies during the last decade have looked at that. How aggressive should we be by managing diabetes? How low should we go with our hemoglobin A1C to preserve these patients from the morbidity and mortality of diabetes? And surprisingly, most randomized clinical trials have not demonstrated any beneficial effect of intense therapy versus conventional therapy for macrovascular outcomes. And when I say macrovascular outcomes, I refer to lethal MIs or strokes. And this is especially seen in patients that had already had diabetes for a long time, 8 to 12 years. So we're going to review the main 3 studies that have been done looking at that: the VADT trial, ACCORD, and ADVANCE trial. The VADT trial looked at almost 2,000 patients, mean age 60, with a duration of diabetes of 11.5 years. And they divided these patients into an intensive treatment group that would have a hemoglobin A1C of 6, and a conventional treatment group where they were just going to allow a hemoglobin A1C of 7.5. They followed these patients for 5.6 years, and they found no difference in the occurrence of cardiovascular events at the end of the study. And they actually had to stop the study because patients in the intensive group were having a lot more hypoglycemias, 8.5%, compared with the conventional group that was only 3.1%. So this was very concerning. Our VA was part of this VADT trial, and many of our veterans were part of this trial. And Dr. Kusi and Dr. Tripathi were co-PIs in this trial, and they remember how they were pushing to get lower hemoglobin A1Cs, but they had very severe episodes of hypoglycemia where patients had falls and loss of consciousness, and they had to call EMS, seizures, stuff like that. And so this trial didn't show any benefit, actually harm, on being so aggressive. The ACCORD trial was a very large trial that looked at 10,000 patients with a mean age of 62 years old and a duration of diabetes of 10 years. Same idea. Some they would treat very intensively to achieve a hemoglobin A1C of 6, and others just 8. And they follow the patients for 3.5 years. At the end of the study, the study was actually designed for 5 years, but they had to stop it at 3.5 years because they noticed that in the intensive treatment arm, there was an excess of 3 deaths per 1,000 subjects per year. And for the total group, there were 257 versus 203 lethal cardiovascular events. So a lot more people died in the intensive group compared with the conventional group. Now the advanced trial, as the most recent one, it looked at 11,000 patients, same ages, same idea. In this trial though, they wanted to prove that glycoside, that is a sulfonylurea that is used in New Zealand and Australia and over there that we don't have here in the United States, was like the panacea, and it was gonna be like very good at treating diabetes. Didn't show any difference in cardiovascular events, and same thing, shows severe hypoglycemia in the intensively treated group, 2.7 versus 1.5%. So this is good enough. These are very well done, multi-center, very large trials that all lead to the same conclusion. Intensive therapy in the elderly does not work, it actually harms.
And how long was that study? The last one? They had to stop it? Or
No.
the advance?
Yeah, you're right. It was also 5 years. I forgot to put it in.
So
But yeah, they
intensive-
pulled.
I heard, yeah.
Intensive therapy for how long? You said 5 years? Is that?
Mm-hmm.
So they see the patient for 5 years for intensive therapy versus conventional therapy.
Right. They were treating the patients. Well, in the advanced trial, they started with glycoside, but if they would need something else, they would add on more and more and more medicine until they would bring the hemoglobin A1C to less than 6.5. In the conventional group, they were just allowing the patients to live at around 8.
It's interesting that the most trials have the duration of diabetes like 8 to 11 years. That's
Right.
a long time.
Right. Well, these are all 60-year-old patients, and so it's relevant for for us, because most of the patients we see have had diabetes already for a long time.
Well, I mean, it does make sense that there's no difference in the cardiovascular event because, I mean, damage is already, the atherosclerosis is already there.
Exactly.
Probably so.
Right. But the thought was, you can prevent the atherosclerosis is already there, but by controlling your sugars, you might prevent heart attacks. That was the thought. Proven not to be true.
Is the A1C number what caused the damage, or is it the drugs used?
They had hypoglycemia, I guess, they were trying to force it down.
They're using insulin and sulfonylureas and everything.
In the VADT, they use insulin. In the Accord trial, only 33% of the patients use insulin. So the hypoglycemia was not only due to insulin.
How about sulfonylureas?
They use sulfonylurea on all 3.
So, what are the thoughts as to why this was occurring in terms of the 6% and having excess mortality and adverse events?
There are different theories, none of them really proven. They think maybe sulfonylurea might have some adverse effect on the receptors on the heart, and might lead to arrhythmias. Same with insulin. Insulin is a growth factor, so we don't know if it actually stimulates endothelial cells, and it can make atherosclerosis to get worse. But they're all hypotheses. Nothing is being proven. But these patients die from arrhythmias. So
Did they know that for sure?
it might, most of them, there are no records on what this
Cause
patient
of-
dies, because
cause
this
of
patient
death
is unknown.
Yeah, right. You
But
can't
when
really
they've
know.
gone back and look, and it's not here, but in the NICE sugar trial, most of the patients die from arrhythmias. And one of the hypotheses is when you give insulin, you're pushing potassium into the cells, so we don't know if that's depolarizing the heart and somehow inducing to lethal arrhythmias, B-tags and stuff like that. So after all those studies came out, Well, so then the question was, so then how aggressively should we treat then our patients? Is there any benefit at all of achieving an hemoglobin A1C of 7? And so there are other studies, the UKPDS and the Kumamoto trial and another arm of the ADVANCE that have looked at microvascular endpoints, reduction of neuropathy, nephropathy, and retinopathy in diabetics. And the UKPDS, for example, found that 1% fall in hemoglobin A1C was associated with a 35% reduction in microvascular endpoints. And that's very significant. If you can reduce, retinopathy, nephropathy, and neuropathy by 35%, that seems to be a very reasonable goal. In addition, sustained periods of glycemic control in newly diagnosed patients with type 2 diabetes has lasting effects in reducing microvascular disease. So what they found is that patients that were newly diagnosed type 2, if they were aggressively treated at the beginning, tightly controlled at the beginning, there is kind of a memory effect that saves these patients, that even if they relax a little bit their control in the future, if they were tightly controlled at the very beginning of the diagnosis, they have less incidence of retinopathy, neuropathy, and nephropathy. Okay?
That study isn't only elderly though.
No, the UKPDS was newly diagnosed diabetics, all
I
ages.
mean, it's interesting how it improves the microvascular endpoints, but then not the macro. But
Mhm.
even though there's a little bit.
Well, but part of it is, what he brought up, that was that, these patients on these other trials had already diabetes for a long time. So maybe the atherosclerosis was already there. And really, once the atherosclerosis is being established, having your sugar in 200 or having it in 90 doesn't make any difference for when you're going to develop a cardiovascular event. But the UKPDS didn't found, in newly diagnosed, tightly controlled, they didn't found any decreased incidence of cardiovascular events. So UKPDS is different from the other trials in the duration of diabetes of the patients recruited, and still didn't show any benefit on macrovascular endpoints. So after all this information is being out, people has been concentrating on preventing cardiovascular events by attacking other risk factors more, like having very tightly controlled blood pressure and very tightly controlled dyslipidemia instead of hyperglycemia. And there are many studies now showing that if you have to pick between diabetic meds or dyslipidemia meds and antihypertensive meds, if you have to pick, you should go with antihypertensives first, since those are the ones that have the strongest benefit in preventing cardiovascular events. So I'm reviewing all this information with you just because it's important and it's relevant to our practice, but not to say that we're not going to treat diabetes. We know elderlies are more sensitive to get dehydrated with hyperglycemia than a young person. A young person can walk around with 400 for a week, nothing happened to them. An elderly has 400, they have polyuria, they get dehydrated right away. They're a lot more sensitive to these osmolar changes. So the idea now is prevent acute complications like dehydration, hyperosmolar state, diabetic coma, but not to be too aggressive, because when we're very aggressive, we can lead to hypoglycemias, polypharmacy, and unnecessary cost. So we have to put those in balance and get to a middle point where that is the best for our patients. So the American Geriatric Society and the American Diabetes Association have come up with these recommendations. There is an appropriate for a fit elderly patient who have a life expectancy of over 5 years, hemoglobin A1C of 7 is reasonable. But for a patient that have a life expectancy of less than 5 years and has many other comorbidities, a hemoglobin A1C of 8 is appropriate. So a hemoglobin A1C of 8 is appropriate for patients that have history of severe hypoglycemia or recurrent hypoglycemia, limited life expectancy, advanced micro and macrovascular complications, extensive comorbid conditions, and long-standing diabetes. Does that make sense? So from the idea now is to individualize every elderly and look at them, as a whole. Are the goals of treatment for every elderly should be defined based on their cognitive status, their functional status, the other comorbidities, duration of their diabetes, life expectancy, and social support available to them. So not because you're above 65, you're going to be in the box of hemoglobin A1C of 8. If you're a fit, cognitive intact, elderly, that has very good social support, is educated, and is motivated enough, you should aim for a hemoglobin A1C of 6, just like a young patient. But if you have an elderly patient of 80 with multiple comorbidities and stage renal disease, there's really no point on aiming for a hemoglobin A1C less than 8. Okay, so now we're going to move on into reviewing the available agents that we have to treat diabetes. Metformin, the main good thing about metformin is that decreases hepatic glucose production. So it's very good in these Mexican Americans that have lots of glucose production overnight by the liver, because it suppresses glucose production by the liver. It is the one that has the most that produces the most reduction of hemoglobin A1C. It reduces the hemoglobin A1C from 1 to 2. No other oral hypoglycemic does that. And it should be the first line therapy if there are no contraindications. So the good things about metformin is that doesn't cause hypoglycemia, may cause a little bit of weight loss, and decreases triglycerides and free fatty acids. So those are very good things. The bad things about metformin, and that limit our use in our elderly patients, is that it can induce GI side effects, but that's not as bad. If you start a low dose of 500 and titrate it up slowly, usually they don't have the GI side effects. But it can cause lactic acidosis. It's very, very rare, but it can happen in patients that have severe CHF, New York classification 3 or 4, or that has a creatinine clearance less than 60. And many of our patients have that, so that's a big limitation. And really the ADA said that we should avoid it in patients older than 80. So that's a good portion of our patients. Something interesting about metformin in the elderly, and that can be a geriatric board question, is that metformin reduces intestinal absorption of B12 in up to 30% of patients, and lowers serum vitamin B12 in 5 to 10% of patients. And we know B12 in the elderly is very important, just because we need it at a higher level. We like it to be at around 400 for the cognitive issues and the cognitive benefits of B12. And metformin can interact with its absorption. So they recommend that we should check not only creatinine, but I'm doing this. Am I doing this? That we should check vitamin B12 if we see that the patient are developing megaloblastic anemia under CBC, and replace as appropriate. Okay, so that's for metformin. For sulfonylureas, well, we all know the mechanism of action. It decreases hemoglobin A1C somewhere between 1 and 2%. The downsides of sulfonylurea are the weight gain that can cause, and it's mainly because since it's an insulin secretagogue and insulin is a growth factor, it can induce weight gain. The hypoglycemia is the biggest issue. Is more common in the elderly, and this is another geriatric board question. You need to know the half-life of the sulfonylureas, and if you're going to pick a sulfonylurea for an elderly, you want to pick the one that has the shorter half-life, and that one is glipizide. You don't want to use any of these ones because they last a lot longer in the system, and since they all have decreased creatinine clearance, it's going to lead to hypoglycemias easier.
What about using sulfonylureas in people with renal insufficiency? Or is that maybe one of your bullets there, I think? I mean, what would your, is there, there's not a recommended cutoff?
No, there's
and
not.
How about dialysis patients?
There's not a recommended cutoff for when you cannot use it, but we know that as the GFR goes down, the sulfonylurea lasts a lot longer, and also insulin lasts a lot longer. So you're not only the sulfonylurea lasts longer, but the sulfonylurea is an insulin secretagogue. So every time you secrete insulin, that insulin is going to hang around for a lot longer.
Do you have a sense of what any specific recommendations on dialysis patients?
No, but we have them on glipizide. We just like glipizide more than any other.
So the dilemma for me is that a lot of the geriatric patients have.
And metformin should be your first line agent, well above sulfonylurea. If you have a GFR 60 or 70 but they don't have CHF, and they're not acutely ill, nausea, vomiting, if their CHS is stable, is not contraindicated.
And of course, you don't stop it if they've been stable. If they reach 80 and they still need something.
You should continue it. You should continue it.
How about if it's less than 60 but 50 or 60? Then
We always like metformin more than sulfonylureas. Yeah. If their CHF is stable, they're not, at risk of dehydration. If this is, a patient, in the social, background is not good, you think that nobody's going to be watching on them, they can get dehydrated and they can go into lactic acidosis, that should be a concern. But if it's somebody that has good social support,
am I going to help the kidneys to help with control of the microvascular property to control the diabetes? I don't know, it's kind of my logic.
if you know your patient well, you think it's safe, the CHF is stable, you can continue metformin. We keep our patients, we rarely discontinue metformin in patients that come to the diabetes clinic on metformin unless they're in full-blown kidney failure, but if they've been on it for longer, we keep it. If we don't think they're at risk of developing lactic acidosis. Another tricky thing with sulfonylureas is that we should instruct our patients that they should not be drink their sulfonylureas if they are gonna exercise or they're gonna miss meals. And we know our elderly they're left alone during the day and they have very erratic dietary habits, and that's when the hypoglycemia becomes an issue, when they have their sulfonylurea 3 times a day but they're missing 2 meals a day. And also if in patients that they have alcohol abuse, that's when also the hypoglycemias are a big issue. TCDs. And so TCDs are very good medicines. They improve insulin sensitivity by inducing maturation of the fat cells in the subcutaneous tissue. So it causes redistribution of fat, and all the fat that is accumulated in the peritoneum is redistributed to the extremities, and that's how the insulin resistance drops. It lowers hemoglobin A1C by 0.5 to 1%, and it has all these good things. It doesn't cause hypoglycemia, that it can be used in patients with impaired renal function. It has beta cell preservation and improves lipid profile, but it has the big caveats that is more expensive. 1 month worth of metformin costs $15 to $20, while 1 month worth of pioglitazone or rosiglitazone can be between $70 to $90. So it's more expensive. It can cause fluid retention and cardiovascular events. And there is now a new issue on TCDs causing osteoporosis and fractures. So those are all kind of...
Now, in the VA, I think we have trouble getting this, right? As far as I know, there's some sort of...
No, we can get the PO.
You can get the PO, but I think the road is...
Don't you have to jump through even a hoop for PO, or did they change that again? Or-
Yeah, Rosie, I mean,
Yeah.
forget it. But
Okay.
PO, yeah, so you can get the PO.
I thought it had to go through some kind of special committee or something.
There is a non, I mean, there is not even non-formulary. I think you just have to prove that they have
Okay.
failed therapy on 2 agents. So if they're metformin and sulfonylurea, you have to move on to TCDs. So the issues with heart failure, well, this is very debatable. Does really rosiglitazone causes cardiovascular events? Does it really cause heart failure? I think the heart failure issue is already set. Yes, it does push patients into CHF exacerbation. The cardiovascular issue is still out there. Many authorities feel like it doesn't cause MIs. Some do, but you should know that about these 3 good studies. This study looked at mainly older patients with diabetes, that they were primarily being treated with rosiglitazone, and there was an increased association of congestive heart failure, acute myocardial infarction, and increased mortality when compared to any of the other oral hypoglycemic agents. That was JAMA 2007. Then in the Arts of Internal Medicine 2008, they looked at an even bigger core of patients, that they were all seniors, and they looked at all-cause mortality and congestive heart failure in patients that were treated with rosiglitazone compared with pioglitazone. And the patients that were treated with rosiglitazone had a lot higher mortality. Okay? And from a meta-analysis of 42 trials of rosiglitazone, it's been demonstrated that there is an increase in myocardial infarction compared with any of the other medicines we have. So if you compare Rosi with metformin, sulfonylurea, insulin, there is always a higher chance of having cardiovascular events when you're on rosiglitazone. So even though a lot of people still debate it, with that information out there, you should probably not prescribe rosiglitazone. Another big study that is important to know for the TCDs is the ADOPT trial. It was a randomized control trial that looked at the long-term efficacy of monotherapy in recently diagnosed medication-naive diabetic patients. The endpoint was to look at the time of monotherapy failure, and they call monotherapy failure a fasting blood sugar greater than 80. So basically, in other words, what they were looking at is they were looking at how long could you keep a patient on one medicine before you would have to add another one to keep a fasting blood sugar less than 180. And they followed these patients for 4 years. What they found that at the end of 5 years, 140 patients were on had failure to monotherapy with rosiglitazone. 200 patients had failure to monotherapy with metformin, and 300 patients had failure to monotherapy with geri-ed. So after 5 years, you cannot go much longer with monotherapy alone. The cumulative incidence of monotherapy failure was 15% for rosiglitazone, 20% for metformin, and 30% with geri-ed. So that study showed that rosiglitazone has a good effect in beta cell preservation because it decreases the need of another agent because your beta cells is still producing some good amount of insulin. And from the ADOPT trial is where all these issues with the fractures came out. They, at the end of 5 years, they noticed that many females, a lot more females, had reported fractures in the rosiglitazone group compared with the metformin and the glyburide group. So they noticed that at the end of 5 years, the cumulative incidence of fractures in the rosiglitazone group was 15%, different from the glyburide and the metformin group that was only 73%. So there was double incidence of fractures in the patients that were on rosiglitazone.
You may not have looked at it, but the women, were they on, like, were they already diagnosed with osteoporosis, and if so, were they already on
Yeah, they did subgroup analysis and they didn't find that there was increased risk factors in the rosiglitazone group females compared with the other ones. This is in females. The interesting thing is that when they looked at all the patients, they said, oh, there's more fractures in the rosiglitazone treated patients than the other two groups. But when they divided into females and males, there's no difference in the males. Even though that study had a lot more males than females. But there was a significant increase incidence of fractures in the females treated with rosiglitazone. So since then, now in the diabetes clinic, when we have a patient that is, on steroids, already has diagnosis of osteoporosis or has big major risk factors for osteoporosis, we try to avoid TCDs in general.
So it's not hard to pass, but
No,
pretty hard.
it's not like if you have a very poorly controlled patient, you already failed metformin, you cannot have sulfonylureas because they're having hypoglycemia. You can move into TCDs, but you just have to keep it into perspective. It's not a complete contraindication. What's important to know between Rosi and Pio is that pioglitazone definitely has a benefit over Rosi in improving lipid profile. This is Pio here. Pio is the white dots. So you can see how Pio compared with rosiglitazone decreases triglycerides nicely, and it increases HDL a lot more than Rosi does. There's no difference really on LDL with the two TCDs, but there is on triglycerides and HDL. Okay, that's what we have for TCDs. Now the new medicines that we have to treat type 2 diabetes are the incretin medications. So incretins is a hormone that we produce in the small bowel. When we eat, the small bowel stretches, and when it stretches, it produces incretins. The incretins stimulates insulin secretion by the pancreas, it blocks the glucagon production by the liver, and it decreases appetite stimuli. So it makes the patients eat less. And that's the biggest benefit of the incretins, that induces weight loss. Do we have until 1? Okay. The two incretins we have now is the GLP-1 analogs that is called exenatide, commercial name is Byetta, and the incretin enhancers. Sitagliptin, the commercial name is Januvia. What the exenatide is basically incretin itself. What the sitagliptin is an inhibitor or the DDP4 enzyme. And the DDP4 enzyme is the enzyme that catalyzes the incretin. So by inhibiting the DDP4, you're just making the incretin last longer in the system. Your endogenous incretin to last longer.
So the Byetta is an analog. It's like a synthetic.
Right. Byetta is incretin. Byetta is GLP-1. But sitagliptin is just blocking the enzyme that catalyzes GLP-1. So it lasts a lot longer in the system. So exenatide is FDA approved as an adjuvant therapy for patients unable to reach target hemoglobin A1C on maximum dose of 1 or 2 oral hypoglycemics. So this is your patient that is on metformin, is on glyburide, and they're still super obese, they're not making any improvement on the hemoglobin A1C. So then that's when you want to use Byetta. It lowers hemoglobin A1C by 0.5 to 1%. It doesn't cause any hypoglycemia. And it doesn't need any adjustment of the dose for creatinine clearance greater than 30. So those are two big pluses. The downsides, though, are that it can cause nausea and vomiting since it slows down gastric emptying. So for diabetic patients that have gastroparesis are contraindicated because they're going to feel very, 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 very sick when they eat. The key is to start low and go slow. You have to start at the lowest dose, that is 5 micrograms sub-Q once a day, and then titrate it up as the patient tolerates it. It should be given just before meals at the beginning, so the patients are not distended by the time they start eating. It can potentiate the hypoglycemia induced by sulfonylureas, so you want to decrease the dose of the sulfonylureas when you're going to start a patient on Byetta. And pancreatitis, we've seen like 2 in the clinic, so it's very rare. It's very, very rare. There's really not much to worry about, unless the patient has history of pancreatitis in the past. Sitagliptin is being FDA approved since 2006 for adjuvant therapy when patients have failed 2 or 3 agents. And it can be used as a monotherapy when all the other possibilities are contraindicated. The good thing is that it's well tolerated, doesn't cause any nausea, vomiting. It can be used in chronic kidney disease and is weight neutral. But the downside is that it can potentiate the sulfonylurea-induced hypoglycemia, and there are very rare cases reported of anaphylaxis, angioedema, and Stevens-Johnson. And it's fairly expensive. We have to get it through the MAP office. We don't have it at the VA at all, but for our UH patients, we have to get it through the MAP office. Okay. So titration. Titration is really the key in treating type 2 diabetes, especially in the elderly, to prevent polypharmacy. We see a lot of patients that get referred to the diabetes clinic and they're on metformin 500 twice a day, sulfonylurea 5 milligrams twice a day, Pio 15, and so we're like, maximize one drug before you move to the next one. Okay, you don't want to have your patients in 4 or 5 different pills halfway with all of them. You want to maximize one before you move to the next one. Okay. I'm not a big fan of these combination medicines. They sell it to you, there's 2 medicines in one, you can improve compliance, they don't have to take so many pills. But if you see, the glucovans is 505, and really the therapeutic dose of metformin is 2 grams twice a day. So to get the max dose of metformin, you would have to give 4 pills. But then when usually, PCPs get to 4 pills, then the patients start having problems because they're already taking 20 milligrams of sulfonylureas. So they start having hypoglycemias. And so then you're not maximizing your metformin because you cannot go up with the sulfonylurea. So better, we're not fans of these combination drugs. They're really just very hard to manage and titrate. This is my one slide on insulin. And that's really all you need to know, right? She knows. That's really all you need to know. If you know that, you're good. When you have your patient in the clinic that is on max dose of metformin, 2 grams twice a day, sulfonylurea is not working, TCDs, let's say you're on Pio 30, and the hemoglobin A1C is high, you just want to start 1 shot of insulin a day. Don't start Detamir 5 twice a day. No, just start 1 shot a day. Because what you really want with the insulin is to suppress the glucagon production at night and bring your fasting blood sugar to a target. So play only with that and start 1 shot of insulin at night. You can start with 20 units. That's good for everybody because the average patient is 70 kilos. And, when I was in internal medicine, I always was wondering, they tell me 1 unit per kilo. You're not going to start these patients in 70 units of insulin. You'll kill them. So that formula doesn't really work for the outpatient setting. Just start them on 20 and teach them how to titrate. You tell them, okay, you're gonna check your fasting blood sugar tomorrow, and if it's greater than 120, go up 1 unit. If they're afraid and they, you can sense their comfort level, and you can say, okay, just go up 2 units every week or something like that. Just, some patients are very motivated and they're like, okay, I'll go up 1 unit every night. Some will be like, no, I'm afraid. So you just can tell them, okay, go up 2 units every week, but go up, just move. Don't stay on the same 20 units. And then when you see them in 3 months, when they come back to the clinic, they'll be on 30 or 40 units. And you tell them, as soon as when your fasting blood sugar gets to 120, somewhere between 100 and 120, stop. Now, if you're having hypoglycemias, go down 1 or 2 units. And that's how you find out what's the good dose for that patient. And usually that works for 80%. Usually that works for the big group of patients. When you start insulin, discontinue sulfonylurea. It's going to get you in trouble. Especially if you're using long-acting like Lantus at bedtime. Stop your sulfonylurea. And only when your fasting sugar is at target, consider start short-acting insulin with meals.
Are there any new recommendations or considerations as to when you would start somebody on insulin? Is it still like if they're maxed out on, is it like 2 or 3 years?
Yeah, if you're maxed out on your oral hypoglycemics and your hemoglobin A1C is still not at target.
When you start someone on insulin, is it really needed to keep the patient on other medications? Actually, I mean,
You want yes, it's a type 2. You want your metformin on board. You want your PIO on board.
But I thought that, what I learned from past is like insulin can replace any other medication. The only one that
You're gonna keep waiting.
the only one that really helped the insulin is metformin because it's increased sensitivity of the insulin, so you don't need that much insulin.
Now remember that TZDs preserve your beta cell function. Okay, so if you can keep those TZDs on board, you're doing very good for that patient because you're preserving the beta cell function. So you're giving them years of them being able to squeeze as much insulin they can from that pancreas.
So what difference does it make if the patient is already on insulin?
Well, because your 20 units is not what you're giving them a hint, but you're not giving them a full dose of insulin. We produce a lot more than 20 units of insulin a day.
Just doing it to keep the sugar.
Well, I thought it's like giving a shot is giving a shot. It doesn't really matter if it's like 20 or 100 or 200. I mean, I don't know. It's like, you know what I mean? Well,
And you really want to keep the idea is to keep the insulin sensitizers on board, because let's say if you have your patient in clinics has type 2 diabetes, he has a hemoglobin A1C of 9, okay? And you say, okay, well, it got the time that I'm going to start you on insulin. Let's stop everything and just put you on 20 units of insulin. You're going to need 100 units of insulin to get that hemoglobin A1C down to a decent level. And you don't want to get there. You just want to give them a hint. With the insulin, you're just giving them a help. But really, the metformin and the PIO are the ones that are doing all the work at maintaining your insulin resistance at the lowest possible.
Andrea,
Yeah.
as far as the dosing at night, I know I had one patient who swore he would get hypoglycemic because he didn't really eat a good meal at night. He'd eat, breakfast and lunch, kind of wouldn't do a dinner thing, even though I tried to convince him how long-acting Lantus was, and it's really no peaks and those kinds of things. Is it causing any trouble if we switch it to the morning just for their
No.
ease of mind, or will they still have the
No,
benefit
with
of the
Lantus it
decrease?
doesn't.
Yeah.
With Lantus
But with
it doesn't really matter.
Delamere,
With MPH or Delamere it would, but the half-life is 16 hours. I mean,
Not
you
huge.
individualize for patient convenience, and you have to convince them, that
gonna
what
be
you're doing
okay.
is good for them. So yeah, it doesn't really matter. The pre-refill insulin pen are a great thing for your diabetic patients. That's if you've looked at the insulin syringes and you look at your patient, you're like, there's no way. I mean, the lines are so little, and to do now when you expect them to do a little bit of the long acting with a little bit of the short acting, all that they don't do it right. When they don't have the cognitive abilities or the visual acuity or the motor skills to withdraw the insulin from the bottle and then mixing it, that's just too much. That we're expecting too much from our elderly patients. And most of these patients are at home, the caregiver goes to work during the day, and God knows how much insulin they're giving to themselves during the day. So the pre-refill insulin pens are really helpful.
Can we get these in the VA?
I think you can just have to do a non-formulary form. I know that at university you can get them with no problem. So whoever is doing the UPG, who is doing the UPG clinic? Nobody? Well, at the NICS you can get it with no problem. But at university side, we don't need anything. CareLinks cover the Novoline pen, the Lantus pen, the 7030 pen. In the clinic, in the diabetes clinic, we all give them just pens. They get the pen. Because you just put the dose in
So
the little
they draw it
monitor.
up themselves, or are these?
No, it's pre-refill. So the insulin is here, and this is the pen, and you just tell them, okay, I want you to do 20 units at night. So they just roll this little thing until they get here 20 units, and that's it. And so
they don't have to stick it in a bottle to get it?
No, nothing. They don't have to worry about keeping the
So there's
insulin in the
it's already filled.
refrigerator.
So how many doses are in one pen?
One dose.
One dose. So they
Yeah.
have to have all those pens. They have to have 30 pens in the refrigerator for a whole month?
Oh no, I mean, this is worth a month or two.
The pen has the
The
stuff
pen.
in it. Okay. All right.
Yeah.
It has a certain amount of units, and then you have to decide how much units.
It has like 100 units or more.
100 units.
Yeah.
It's like one vial in a pen.
100 units.
Okay.
The vial is in
The
here.
vial is
Yeah,
part of
okay.
the
20
pen.
units.
About 1,000 units.
And then they just put on a syringe.
No, they don't. No, they don't need to do anything. The needle is here, and the needle only needs to be changed every 3 days.
And they can do that. Most of our.
Oh, they can do that. Or the caregiver can do it at night. The thing is that you have it set up for them. The caregiver goes, and they just have to just push this button, and they will get the appropriate dose of insulin. So that's really, really important on them. That's really helpful. Okay, here's the algorithm, but you guys have the slides, right? You guys have the
I'll make
slides.
sure they get them.
Memorize that.
Okay, well let's finish our case then. So that patient that we discussed at the beginning, we started him on metformin and an ACE, since it's more important to treat hypertension than hyperglycemia. Then 4 months later, the patient is still trying to lose weight, but with no improvement. The hemoglobin A1C is still high, so we can add a sulfonylurea. 4 months later, the patient continues to gain weight, now more so than he's in a sulfonylurea. The hemoglobin A1C is still not much better, so we can add an exenatide, 5 micrograms twice a day. And when we do that, remember you have to decrease the dose of the sulfonylurea. Then on exenatide, the patient starts losing weight. He decreased because he has decreased appetite. His hemoglobin A1C improves. He had a little bit of nausea at the beginning, but had only one episode of hypoglycemia. So we go ahead and increase the exenatide to the max dose and discontinue the sulfonylurea.
So you wouldn't use them both because the Byetta makes you more susceptible to the hypoglycemia?
Right, you can use them both, but if you start having issues with hypoglycemia and the patient already has a target hemoglobin A1C,
Okay, and get rid of the one.
get rid of the one that you don't need. 1 year later, weight has fallen from 300 to 282. The hemoglobin A1C decreased to a target. The blood pressure is good, and the fasting lipid profile is improved because as the sugar improves, the triglyceride improves. So you don't need to add another medicine. You just need to get to a
And he was
target
on a
hemoglobin
TCD.
A1C. And he was on a TCD. Okay. I don't know if we have time. We're just gonna leave it like that.
He lived. That was the good news is he lived.
Thank you.
Live.
Is it
A long and healthy
with better
life.
health?